So, hello friends. So today I'll be talking on this 46th COVID-19 update. So it's 23rd April 2021. So I'll be talking on these two new agents, Itolizumab and Bevacizumab. So in I think couple of updates before I did talk about Tocilizumab. So as you're all aware, friends, we're in the thick of battle against COVID in India. And we recently reviewed the remap cap study of Tocilizumab, and we realized there may be some merit in using Tocilizumab in saving lives. And after this, the huge surge in India is led to deficient availability of Tocilizumab. And all my doctor colleague friends are desperately scouting in utilizing this Itolizumab and Bevacizumab, more so Itolizumab, so which is produced in India. So we'll just review, is there any science and what is the science behind usage of this, and whether there is some reasonable body of evidence in using any of these drugs in severe COVID in saving lives in our nation. So that's the purpose of this sort of a update. So, so if you scout for the studies, there's not many studies on Itolizumab. So there are basically three studies. One has come from India, and Itolizumab, as you know, is produced by Biocon company, which is present in Bangalore. So, and this is a study which came out from the company itself. So this study was funded by Biocon, and it came in it came in this journal Experimental Opinions in Biological Therapy on 16 July 2020. And there was a review article also that came after this on biodrugs 13th October 2020 on Itolizumab. So what is this drug Itolizumab? So basically this is a monoclonal antibody. It's an anti-CD6 monoclonal antibody. So you have these lymphocyte with the CD6, and these antibodies are directed against this CD6. So basically this monoclonal antibodies, by acting against the CD6 component of the lymphocyte, suppresses the activation of lymphocytes and causes downregulation of pro-inflammatory cytokines and the adhesion molecules. So this is the mechanism. Basically, it works against the CD6, and it tends to suppress the activation of lymphocytes. And this suppression of lymphocytes leads to downregulation of production of pro-inflammatory cytokines and adhesion molecules. So this Itolizumab basically was approved for its usage in severe psoriasis in 2013. So moderate to severe psoriasis was the indication for the usage of Itolizumab, and this drug was approved for that in 2013. So the Cuban scientific community did realize that this drug has an ability to ameliorate or diminish the cytokine release syndrome that typically happens in COVID. So the Drug Controller Government General of India approved its usage in July 2020 after reviewing the phase 2 study as a part of a treatment armamentarium against COVID. So this has got a recent approval in the thick of COVID pandemic in July 2020 by DCGI. And that's when many of our doctor colleagues have experimented with using this drug in COVID. So there is only one study that has come from India. So it's a phase 2 study. It was a small study which was funded by the Biocon, and it was done in 30 patients across 4 hospitals. So let us look into the mechanism of action. As I said, this is an anti-CD6 monoclonal antibody. So basically it acts against this receptor called scavenger receptor 16 rich domain 1. So that's the receptor against which it acts. And this receptor is a 148 kilodalton with 2 chains, heavy chain and light chain, which is bound by disulfide bridge. So the mechanism of action is, so if you have this typical lymphocytes, which expresses 3 CD6 components, and Itolizumab monoclonal antibody acts or binds to these CD6 component. And these CD6 components, which are typically present in T cells, B cells, and B1A cells. And by binding to these, it potentiates the proliferation, adhesion, differentiation, and survival of these cells. And this leads to activation of the Th1 cells. and that leads to downregulation of pro-inflammatory cytokines and adhesion molecules. So basically, one thing the listeners can only remember is possibly itolizumab acts against this CD6 component of lymphocytes and leads to suppression of this activation of lymphocytes and Th1 activation, leading to downregulation of production of all the cytokines, pro-inflammatory cytokines and adhesion molecules. And the usage of this has shown to reduction in the interferon gamma, IL-6, and tumor necrosis factor alpha. So we know for sure that tocilizumab is specifically the IL-6 receptor antagonist. So this acts at a little general level where it leads to suppression of the activation of lymphocytes or activation of Th1 cells, leading to downregulation of all the pro-inflammatory cytokines, and amongst which IL-6 also is reduced by usage of itolizumab. And so what they found is in presence of activated lymphocyte cell adhesion molecule and interleukin-2 in the circulation, so there is extensive proliferation of the T lymphocytes, and itolizumab is shown to inhibit. So in the presence of activated leukocyte cell adhesion molecule and IL-2, there is extensive proliferation of T lymphocytes, which is inhibited by this itolizumab. And itolizumab is also shown to downregulate the phosphorylation of intracellular components within the immune cells. So these are some of the mechanism of action. So when it comes to safety and monitoring, I'm sure friends, many of you would have used itolizumab. So as soon as we start the infusion, what typically we have found in COVID patient is they could have extensive chills and rigor. So this is the commonest side effects that we have witnessed. And some of the patients do develop severe bronchospasm, and we have used it in a couple of patients, and we have seen severe bronchospasm in certain patients. So this medicine, when you are giving, it is advisable that they are pre-medicated with Avil and hydrocortisone to reduce these side effects. And then it is important that one has a crash cart ready when you are using it in a non-intubated patient. So we've had a serious reactions to this where patients have desaturated after we have infused this itolizumab. But what is reported in this manuscript is mainly dizziness, and the side effects are reported in 12 to 15% of the patients. Patients can have headache, can have vomiting, and a lot of skin manifestations are reported. So we have seen in a couple of patients developing rashes. So we see maculopapular rashes, or there can be severe itching, or there can be urticaria. Lymphopenia can happen after administration of this itolizumab. And as I said, wheeze and short of breath. I think this is the commonest manifestations that we have witnessed in ICU. So they can go into bronchospasm. So all the listeners, be careful when you're giving itolizumab. Always pre-medicate with hydrocortisone and Avil, and have the crash cart ready with nebulization, adrenaline, and all that stuff. And more than 5% of the patients have had diarrhea after itolizumab usage. So these are some of the typical side effects of itolizumab. So this is the pictorial representation of how itolizumab acts. So basically, as you see here, the itolizumab basically binds to the CD6 component and leads to activation of the Th1 cells and leads to downregulation of production of pro-inflammatory cytokines. And without itolizumab, as you see, so these CD6 are not bound to any of these, and they release a lot of these cytokines. All these small things are cytokines. So this is a pictorial representation for you to remember how typically it acts. So let's look into clinical trials of itolizumab. Honestly, there are not many trials, and as you see, there's only one trial done, which is funded by Biocon in 30 patients. So in this study, the inclusion criteria was age more than 18 years. And they took patients who were saturating less than 94% and needing supplemental oxygen, or PaO to FiO2 was less than 200. And they took patients where inflammatory markers were elevated. Ferritin had to be more than 400 nanograms per ml. And interleukin-6 levels they did, and it had to be more than 4 times the upper limits of normal. Exclusion criteria was serology had to be negative. Absolute neutrophil count should be less than 1,000, or absolute lymphocyte count should be less than 500 millimeter. And they should not have any underlying tuberculosis, and platelets should not be less than 50K. So these are some of the exclusion criteria. And the dosage they used was 1.6 milligram per kg as infusion. And after 1 week, if patient's condition did not improve, a second dose could be given with clinical discretion at half the dose, 0.8 milligram per kg. So these are some of the inclusion, exclusion criteria and the dosage that they used in this study. So 2:1 randomization was done. Primary outcome was to look at 1 month mortality. Secondary outcome was to look at the lymphocyte count, CRP, whether CRP came down, lymphocyte count improved, PaO2, FiO2, and hospital length of stay, and radiological resolution, and remission of respiratory symptoms. So these are some of the secondary endpoints they looked in Itolizumab study. And this is the pictorial sort of a depiction in the manuscript as to without Itolizumab, the inflammatory response was quite accentuated. With Itolizumab, it was curtailed. And these are the different phases of the disease, which most of the listeners would have seen that there are stage 1, stage 2, and stage 3. And it is proposed that Itolizumab has a better efficacy when it is initiated somewhere in the later part of the stage 2 and stage 3, where the inflammatory sort of a cytokine storm sets in, and Itolizumab may be beneficial in reducing that storm. So when you look at the results, so this is basically a very basic statistical analysis they have done. So Itolizumab group, as I said, it was 2:1 randomization, 20 patients in Itolizumab group and 10 in standard group. As you see, patient who went on to needing NIV was less in Itolizumab as compared to standard, 25 and 40%. And all the 20 patients recovered in Itolizumab group, and in the standard group, 3 patients died. And PaO2, FiO2 improved in all the patients with Itolizumab, and oxygen was weaned off at 30 days in all patients in Itolizumab. So basically, this is not a very robust trial, very sort of a simple study without too much of deliberation into the endpoints. And they have looked at IL-6, TNF alpha levels, ferritin, D-dimer, LDH, CRP, and they all showed reducing trends. And the change was in proportion to the clinical improvement. So they did look into inflammatory markers, and it downtrended in the Itolizumab group. So when you look at the Cuban study, so there they found the 79% of the patients who received Itolizumab were discharged at 14 days. So this was the Cuban study. Both are preprint. So it came on 4th June 2020, where IL-6 reduction was found at the end of 48 hours in 24 patients where Itolizumab was given. And there was a reduced risk in ICU admission. And this was another study which was done in 19 patients where they found 10 times reduction in risk of death where Itolizumab was used. So these are the 2 small Cuban studies where they found one study showed reduction in IL-6 levels at 48 hours. Another one showed reduction in the risk in ICU admission and 10 times reduction in risk of death. So this is again a graphical representation of the Cuban study where they found admissions to ICU was significantly reduced in Itolizumab group, and mortality was significantly reduced in Itolizumab group. And this was another Cuban study. There were only 2 Cuban studies. So this was one which looked at the IL-6 levels. As you see, the IL-6 levels were highest in the critically ill patients. This is pre-Itolizumab group. And now you see post-Itolizumab, they found significant reduction in the IL-6 levels, and that was statistically significant. So when you scout for the evidence for Itolizumab, so these are the only 3 studies that you'll find. One is funded by Biocon in a small group of patients, and not a robust statistical analysis and not a robust study, and followed by these 2 small Cuban studies, one looking predominantly at the IL-6 levels, one looking at the ICU admission and the mortality. So this is all is the evidence. So it is good if all my good friends, including me, who have used Itolizumab as a desperate measure in the absence of Tocilizumab, try to collate our own findings and publish it to substantiate whether this is having a good merit in saving lives of our patients who are hugely suffering with the second surge of COVID. So that would be my earnest request. So whoever is using it, please start compiling and collating the data. And it is good to create some registry and collate all these to make some logical conclusions. So now we'll move to this Bevacizumab. So I had not heard about this drug until maybe around 10 days back. So I just heard about this another monoclonal antibody. So there is a sort of influx of all these monoclonal antibodies. So I was scouting for any evidence for this. So I came across this article, efficacy and tolerability of Bevacizumab in patients with severe COVID. So this was a study with a joint collaboration from Chinese and the Italian group. So it's an interesting manuscript. So I urge all the listeners to read this. So basically, Bevacizumab is a monoclonal antibody against the vascular endothelial growth factor receptors. So the whole hypothesis is these vascular endothelial growth factor receptors, when they get activated, they release a lot of these vascular endothelial growth factors. And these lead to a lot of leakage of the blood vessels and then exudation of all the components from or the leaky capillaries or the leaky blood vessels, leading to exudation of the proteinaceous material into the alveolar space, leading to the ARDS. So this is the hypothesis. So basically any injury to the vessel wall due to any inflammation mediated by tumor growth factor, endothelin, or hypoxemia. So when there is an hypoxemia, this vascular endothelial growth factor receptors get activated and they release a lot of these VEGF. So I'll keep calling as VEGF. So they release a lot of VEGF, which basically leads to a lot of organ injury and a lot of exudative sort of a leakage from the vessels. And this leakage can happen from the endothelial cells, immune cells, and from the cardiac muscle as well. So which leads to lot of tissue edema and organ dysfunction. So the Bevacizumab monoclonal antibody, so basically blocks this VEGF receptor, and this VEGF receptor mediated signaling, which leads to leakage of all these blood vessels, is blocked by Bevacizumab. So the whole hypothesis is the ARDS, which typically sets in COVID, can be perpetuated and get worse by leakage of these capillaries, leading to the ARDS. So that is the hypothesis where they have used this Bevacizumab. So this study done as a joint collaboration by Chinese and Italian was published in 2021. So the inclusion criteria they used was patients who were tachypneic at 30 per minute, saturation less than 93%, PaO2 FiO2 less than 300, and radiological evidence of ground glass opacities and ARDS were included in this study. And these patients were followed up for 28 days. So this anti-VEGF monoclonal antibody is basically used in cancer therapy since 2004. And the dose typically they use is 5 to 15 milligrams. So in this particular study, they've used the 7.5 milligram per kg as an infusion for COVID ARDS. So the median age of the patients recruited in this study was 62 years, 77% were males. Typically you see most of the COVID studies, almost all COVID studies have preponderance of male population, and so is the case even in this. So the median duration between the admission and administration of Bevacizumab was 7 days in this study. 50% of the patient had hypertension, 23% of them had diabetes. 13 patients were from China. So they had 27 patients in this study. 13 were from China and 14 was from Italy. So the predominant side effects or the threatening side effects of Bevacizumab that is reported in literature is hollow viscous perforation or gastric perforation, GI bleeds, and nephrotic syndrome. But surprisingly, in this study, they didn't find any of these side effects at the dose they used in COVID ARDS. So what was the results of this study? So basically, as you see, they had 27 patients in Bevacizumab, and they looked at, they gave Bevacizumab and observed how the trends in PaO2, FiO2, and they compared with the historical cohorts where they took 137 patients who were matched with the similar patients who received Bevacizumab, and they compared with their historical cohorts. So they looked at the PaO2 by FiO2 improvement at day 1 and day 7. As you see, a significant proportion of the patient had improvement in PaO2 FiO2 92% as compared to 62% in historical cohorts who did not receive Bevacizumab. And discharge at 28 was more in Bevacizumab group, 65 as compared to 46%. And oxygen deterioration, none of these patients where Bevacizumab was used who were recruited for this had oxygen deterioration, as opposed to 19% in the standard group who had oxygen deterioration. And the median oxygen supplementation, the duration was much lesser in Bevacizumab, which means they were weaned off oxygen sooner than the standard group, 9 days versus 20 days. And chest X-ray resolution at 7 days was significantly reduced in Bevacizumab group. And 14 of the patients had temperature in Bevacizumab, out of which 13 patients, 93% of them showed resolution of temperature within 72 hours after initiation of Bevacizumab. So basically, you'll see all the endpoints which seem to suggest that Bevacizumab does help in improving the gas exchange and reducing the need for oxygen, improving X-ray resolution and resolution of temperature. And they looked at improvement on PaO2 effort in all the patients. As you see, the red one is the Bevacizumab and the green one is the standard. So they had statistically significant improvement when compared to the historical cohorts. And they looked at Chinese patients to see whether there is any demographic differences. Bevacizumab group had improvement in PaO2 effort compared to the standard, and so was the case in Italian group. So this is a nice, interesting curve. So basically, all these little stars you see is patients who fully improved. Diamonds are the patients. This is basically all the 27 patients who are charted on this plot. All these diamonds are the patients who sort of discharged, and rounds one were unchanged. So what you basically see is all the dark red ones are the ones who are mechanically ventilated. And as it keeps getting lighter, so they are getting de-escalated. Basically, you see there is no progression from blue to red. Rather, there is all the patients progress from red to blue, which means they were on a higher form of respiratory support, which then improved to the lower form of respiratory support because the blue, light blue indicates ambient air. So basically, this is a pictorial representation that all the patients where Bevacizumab was used in 27, there was a trend towards oxygen improvement with a good number of patients getting discharged and good number of patients who improved. So that's what this graph indicates. And when you look at the side effects in Bevacizumab, as I said, the threatening side effects of Bevacizumab is GI perforation, hemorrhage, and nephrotic. But what they found is AST-ALT rise was the most commonest adverse effects they found in the Bevacizumab, and that they graded as grade 1, grade 2, grade 3. And the second commoner was a fall in hemoglobin, fall in platelets, and rise in the BUN. So these were some of the commoner adverse events that they found in Bevacizumab group. So all in all, so basically I tried to review the monoclonal antibodies that people are increasingly using. So even now, as I'm talking about this, Itolizumab also is becoming very hard to find because a lot of doctors are using it as a desperate measure to save the lives of the patient. So just to summarize, Itolizumab, there are 3 studies, one funded by India, Biocon, and 2 from Cuba, which shows some signals towards improvement in the gas exchange and improvement in outcome, basically by reducing IL-6 and reducing the risk of death in the Cuban study. And the Bevacizumab is a vascular endothelial growth factor receptor. It acts against that monoclonal antibody, and basically it prevents the leakiness of the blood vessels. So this is one study which was done as a joint collaboration between Chinese and Italians, which shows again signals towards improvement in the gas exchange and resolution of radiology and the overall outcome. And so that's about these 2 drugs. So thank you very much. So you can visit my website, www.drpradeeprangappa.com, to rehear to this lecture to gain some clarity and insight. So I would leave it at that. So I wouldn't make any suggestions or recommendations whether these drugs should be used. But if any of you are using Itolizumab, or I have not used Bevacizumab at all, but after having reviewed this, whoever uses it, I urge every listener to collect the data and create some case series, and our few centers can join together and publish your results, because we can share a lot of insights and justify and substantiate our usage of these expensive drugs to our COVID patients and save more lives. So that's the message I would give. So at the end of these 2, reviewing these 2 molecules, I wouldn't make any suggestions or recommendations. I only say that if you are using it, collect the information or collect all the variables, and please try to publish it. In that, it will help each other in trying to understand more about the effectiveness of these drugs. So thank you, everyone.